My name is Sherene Shalhub. I am a vascular surgeon at the University of Washington. I would like to thank the organizers for this meeting. I'm excited to present to you on two topics. One is the surgical interventions in vascular Ehlers-Danlos syndrome, and the other one is patient-centered research networks, how to organize. For surgical interventions, I will cover vascular surgery principles and illustrate the techniques we use, which include embolization, stenting, and open repair. I will start with some basic vascular surgery tenets. Number one is that the risk of aneurysm rupture and complications has to outweigh the risk of surgery for us to offer an operation. As such, our management approach, whether it's medical or surgical, varies by type and location of the aortic and arterial pathology. And in general, repair indications are tailored to size of aneurysm or complications of dissection. And lastly, we know that the outcomes of emergent surgical interventions are inferior to those in the elective setting. In terms of how this applies to vascular Ehlers-Danlos syndrome, we do know that patients who have an established preoperative diagnosis who are treated in the elective setting have significantly improved outcomes compared to patients who undergo emergency repair and when the diagnosis is not known. And the reason we think this is true is because knowing the diagnosis allows us to prepare for the perioperative and the operative management of patients with vascular EDS by modifying our techniques and being extra gentle with tissues. We do know that the majority of cases with VEDS are treated medically, that means non-operatively, and that makes sense from a vascular surgery perspective since most aneurysms and dissections are managed medically. If an operation is indicated, the most common operation that is offered in people with VEDS are embolization, and that means using particles to block a blood vessel. The next most common are stent grafts, and on rare occasions, open repair is indicated and can be performed successfully. Here are examples of using embolization in patients with vascular Ehlers-Danlos syndrome in the carotid artery, the subclavian artery, as well as splenic artery embolization. Arterial stents are used for medium-sized arteries, and just to be aware, what we're talking about is the use of covered stent, as you can see here on the right. This is to exclude the aneurysms, and this is different than bare metal stents that are usually used to open the arteries. Here are examples of using stent grafts in treating subclavian artery rupture as well as hepatic artery stenting. Aortic stent grafts are ill-advised in people with connective tissue disorders in general, including VEDS. However, we have seen a number of patients with vascular EDS who've had endovascular aneurysm repairs, EVAR, prior to establishing the diagnosis of VEDS, and they seem to be doing well overall. As such, follow-up and natural history studies, such as a longitudinal natural history study, are integral to understanding if this is an appropriate modality of repair. With regards to endovascular approaches, access site considerations are paramount, and particularly in this population because of our concern for developing of pseudoaneurysms at the access sites or prolonged bleeding and hematoma formation. Therefore, there are recommendations in terms of approaching the access site, which include planning for open exposure and repair of the femoral artery and avoiding vessel loops due to the fragile nature of the arteries themselves, using U-stitch monofilament pledgeted repairs for the access site, and avoiding repeated sheath exchanges. And lastly, reinforcing the repair with a circumferentially felt strip or bovine pericardium patch in order to prevent, again, pseudoaneurysm formation. The principles of open surgical techniques in people with vascular EDS is to provide gentle retraction when we are retracting, using pledgeted repairs to reinforce the suture lines, as well as using padded clamps during clamping and making sure that they are not hypertensive during clamping. So we drive the blood pressure down to a systolic of 90 during clamping of the aorta. We also utilize the concept of permissive hypotension. This is allowing people to maintain systolics of 80s during a rupture or an emergency type setting, because we do know that this actually improves outcomes. And this is what we recommend in general for anyone with a ruptured abdominal aortic aneurysm, and we have seen uses of this in trauma situations. We also apply this to people with vascular Ehlers-Danlos syndrome. And certainly there have been data to suggest that the risk of secondary event does increase with the severity of the initial event and may be related to being in the hospital, which may be related to fluid overload, although that's not well established. In terms of spontaneous retroperitoneal or intraperitoneal bleeding, we manage this with permissive hypotension, judicious transfusions, and reversing anticoagulation as needed, as well as admission to the intensive care unit. Angiograms are reserved for cases in which the bleeding has not stopped, and in this case, most of these are managed with embolization. So now that you've heard about surgical management of vascular Ehlers-Danlos syndrome, I will shift now to my second topic, which is patient-centered research networks, how we organize. There are multiple challenges in vascular Ehlers-Danlos syndrome research. For one, medical records alone without actual imaging are not enough to understand the clinical manifestations of vascular EDS. The genotype-phenotype correlation has been difficult to ascertain, especially when the numbers are small. Additionally, there is an element of ascertainment bias because people come to attention when they have severe phenotypes. Additionally, the key element to the creation of effective assessment and management plan for patients with vascular EDS should involve a comprehensive knowledge of the natural history and also to include patient input into research priorities. The first step, and the most important step in creating patient-centered research networks, is to view patients as equitable partners in research. That means that these patients are equitable from the perspective of bringing in their unique perspectives, and they have the enhanced insight into knowledge gaps in research. They should be involved in all elements of research design and implementation, from agenda setting to design procedures to recruitment, data collection and analysis, as well as dissemination and implementation and subsequent evaluation. Involving patients in research results in improved quality of the research design, increased participant enrollment, and decreased attrition over time, as well as improving patients' outcomes. Patient engagement involves reciprocal relationships, i.e., a true partnership that is built in transparency, honesty, and trust, and avoiding tokenism. It also centers around co-learning. The way I think of the engagement strategy is that it is a tri-legged stool of patient-researcher partnership, in which we build infrastructure necessary for researchers to create and sustain partnerships with patients and other stakeholders that will inform their research work, connect stakeholders with the resources and education necessary to build capacity and empower them as equitable and meaningful research partners. And thirdly, by creating cooperative opportunities between patient advocacy organizations to empower them to advance research efforts based on patients' priorities. The outcome of the engagement work involves identifying the key research topics that are amenable to pragmatic clinical trials and comparative effectiveness research design, and ultimately also result in research prioritization. This work eventually can then be translated to research applications that will generate evidence that is patient-centered and relevant to the patients themselves. And here are some lessons that we've learned from patient engagement and research. It's very important to break down the hierarchical structures and level the power structure early. It's also important to be mindful of the team's energy levels and be aware of people's availabilities to participate in this work. It's important to involve patient advocacy organizations early to support the engagement of patients at an organizational and policy level. Also, lessons learned was that social media is a great place to start and to identify patient-led initiatives. And it's important to also help others find you. So it's important to brand your effort and disseminate the information that you are working on this particular engagement work, and create virtual meeting spaces. We started using Zoom meetings before the pandemic, but the pandemic has definitely accelerated the availability of Zoom and people's comfort with using these virtual meeting spaces, such as today. Here you can see all the patient advocacy organizations that we involved early in this work in 2017 when we created the Vascular EDS Collaborative. And over the time of engagement, we were able to create this powerful network of organizations working together in unison towards research priorities in vascular EDS research. We were able to create the VEDS Research Collaborative Study, which is the largest natural history study following people longitudinally, and it involves patients with genetically confirmed vascular EDS. The patients and families as research partners help design the consent protocol, the community participation enrollment of patients, loved ones who have died, and children. They also provided feedback on the study flyers as well as dissemination. The engagement work led to setting the research agenda and priorities, and you can see by surveying the community, we identified multiple topics in the top 5, which included barriers to care, assessment of beta blockers versus other medications, quality of life, exercise roles, and communications and care coordination. As a result of the research prioritization and working with the community, we were able to design a trial called Best Meds for VEDS, which we submitted the LOI to PCORI this past month. And you can see we met in person to design this trial and continued working virtually on the trial design. In closing, patient engagement and research is tremendously gratifying. Recognize that patients are a part of social groups and families and communities, and that these broader networks can be a positive force for change. Also know that what you learn may surprise you. You may go into this with a certain preconceived notion, but you'll be surprised. Lastly, it's an iterative process. The diversity and number of participants increases with every iteration, and it takes time. It takes time to build these networks. It truly takes a village, and I thank all my collaborators and everybody that I have worked with over the last few years. It has been incredibly gratifying, and as you can see, it is a tremendous amount of people who have been involved in this. Thank you for your time and attention.